Selection and orientation, you get the right docs in, again, that's your draft pick. Got to make sure they block and tackle. There's an interesting story. A group of physicians at Washington, you may have seen this story, it was published in the lay press. They followed a cohort of surgeons through their residency program. At the end of them, they labeled great physicians. And the attendings rated them by how they were in the surgical field, how they interacted with nurses, how they interacted with patients, how they interacted with their colleagues, how they supported a group mission. You know, the sort of docs that many of them are in this room, but you think of, you go, gosh, if all the docs were like that, we would just soar. And then they look back in time saying, what is it that would have predicted them becoming a great physician? They only found one thing. And they looked at everything. They looked at age, background, training, board scores, evaluations, interview performance, ethnicity, culture. I only found one thing. Anybody know what that is? The one thing that predicted them becoming a great physician. It is, anybody have a guess? You'll never guess it. No. I've never heard anybody guess this correctly. It is participation in a competitive team sport. Participation in a competitive team sport, because if you're the left tackle of your high school football team and you show up, you go, you know what, I am so sleepy today. Oh, I'm just going to let my guy in. How long does it take for that process to autocorrect? First of all, you wouldn't do that because you get back in the huddle. Think your quarterback's going to have a word with you? Do you think the right guard is going to have a word with you? Do you think the tight end's going to have a word with you? Do you think, I mean, there's such a deep sense of accountability and dedication to the team that you wouldn't even think of, I'm sleepy, I can't do my thing. Because you have a deep sense of accountability to yourself, to the coach, to the team, your teammates, and what you're trying to do together. And this is the great physician, is the team member who's willing to think like that. So, step one, creating physician buy-in. So we're gonna do a little bit of why and a little bit of how. Okay? So we as physicians will do things, again, if we believe that they are worthwhile doing. And I don't have to convince any of you, because I know that you know that delivering the patient experience is critical. But we also have to understand, we make the mistake frequently of, gosh, we need to improve our HCAP scores, let's send everybody to Smile School. When you get the why right, then it's much easier and the training actually takes flight. And to understand what's on the line and what the argument for doing these things. A patient's expression of satisfaction or dissatisfaction is a judgment on the quality of hospital care in all aspects. Whatever its strengths and limitations, patient satisfaction is an indicator that should be indispensable to the assessment of the quality of care in hospitals. It is the patient's verdict. And as I said before, HCAHPS correlates more closely with readmissions and other mortality issues than do many of the quality measures that we use. So the question is, how do we improve it? So, who here, you guys know what HCAHPS is? Who here knows what HCAHPS is? Yeah, that was like, yeah, kinda. But it's the government measure of the patient experience as a standardized effort across the country. It will get more and more visibility. It is entirely transparent right now, hospitalcompare.gov. Any hospital, including your hospitals right side by side to each other, any patient can look it up. And the cool thing is, that you'll be excited, is that that's hospitalcompare.gov. They have physiciancompare.gov, which is the CGCAPS data, which is the outpatient equivalent. So patients now can look at the clinical quality measures, core measures, and HCAHPS scores of any hospital, but probably by the end of this calendar year, early part of 2014, it was supposed to be January 2013, but there's some redesign issues, that any patient can look up any of you and decide whether they want to see you or not, based upon what patients say. So these are the questions. Here's the three, doctors, courtesy and respect, doctor, listen carefully, explanations are clear. You guys know how to do that stuff? courtesy and respect, are those any more subjective than that? Can you, I mean, what's courteous to me may not be courteous to you. Respectful for me may not be respectful for you, and let alone the patient, let alone the family. So I find these questions to be enormously vague. And I have a suggestion. Let's stop talking about HCAHPS. Let's stop talking about patient satisfaction. It is a common strategic mistake that is the downside of the evolution of pay for performance. Pay for performance has never really demonstrated to improve much. Because what happens is because organizations maladapt to it. They become a process-driven, process-centric. We're more concerned about looking good than being good. The true elite organization is about being good. Extracting from the evidence the things that we know work in the patient encounter and doing that as standard work every patient, every time. When we stand up in front of a group and say, we've got to improve our HCAHPS scores, we've got to improve our HCAHPS scores, we've got to, have you guys, are you asleep yet? Because I'm falling asleep saying it. Your HCAHPS, your patient satisfaction, your press gaining, whatever, is the consequence of what we do. It is the consequence of the things that matter. We are in a world now where we have to validate. We can't just say, no. I know our HCAHPS aren't good, but have you asked us how good we are? Nobody cares what you think of yourself. Nobody cares what your commentary or your self-assessment or your self-opinion is. It really is a measurement base. So those measures are important. I'm not saying they're not important, but when we invert the equation and say we must improve our HCAHPS, we're going about it all wrong. It's deciding that this is a worthwhile pursuit. It's determining what are the set of behaviors that we need to deliver, doing it to the best of our ability, every patient, every time, investing in growth and development so we know how to do it, speaking of it to our colleagues, and making it relevant and important and coupled to clinical quality. The consequence of which is, I assure you, if you do those things, these will take care of themselves. So, how good do you think you are? How good are we at assessing ourselves? Again, there's two properties of physicians. One is that we underestimate our influence on other people because we have profound influence if we exercise it. Try going into your clinical environment and huddling with your nurse. Try this with a patient sometime. Try doing this with a patient. Say, you know what? Historically, docs, myself, we haven't been very good about communicating medications. What I would like to do is I want to get better at it. You say that to the patient, your introduction. Say, I want to make sure that every time I describe a new medication, I give you the name of the medication, the purpose of the medication, how long you're supposed to take it, and what the potential side effects are. So let's go through those things, and in the end, I'm going to quiz you to see how you're doing and see what the patient does. Because that composite, that collection of those four things, we deliver less than 20% of the time. And it's funny because when patients rate us how well did the physician explain medications, the average national score is a 91.3, which is usually really good, but actually we suck at it. Patients rate us much better than we actually are by observational studies. Because their inherent belief is that they love us. They want to be able to like us, and they'll grade up, just by halo effect. But in terms of our delivery of those specific issues are important. So how good are we? And if you saw my last talk, there's a couple of repeat slides. Percentage of physicians who thought the patients knew their names, 67%. Percentage of patients that could correctly identify the physician's name, 18%. What we think versus what actually is are two different things. Physicians that believe the patients know their diagnosis, 77%. The percentage of patients that know their diagnosis, 57%. Percentage of physicians that stated they sometimes discuss patients' fears and anxieties, 98%. Percentage of patients that said the physicians never did this, 54%. So what we think and what we do are two different things. So, this is the purpose of measurement. The purpose of measurement is to cast away self-opinion, and this is what I think I need to do, to hardcore measurement. And to allow that to organize and align clinicians to execute a common goal. So, measurement, reporting of performance, and clarity of expectations are requisites for physician effort to achieve an outcome. Measurement matters. That was my Nike Fuel Band. That was not a weird gesture. You're going, what is that guy doing? That was my Nike Fuel Band gesture. There's times when it's 11:30 at night and my wife is asleep and I'll be shadowboxing. She goes, what are you doing? I got to get my 3,000 points. So, is this being recorded? This is being recorded. I got to watch what I say. Anyway, I got to tell you a funny story, though, about the influence of measurement on effort. I have kids. My kids are now 14 and 16. My son's an avid lacrosse player. Is lacrosse big around here? Yeah, anyway. And my daughter's in the high school band, and she plays the trumpet, the very same trumpet that I played in the very same high school band. San Diego's a hard place to leave, when you grow up there. I was actually born in Sharp Hospital, where I now work. So it wasn't a joke. I was laughing back there. I know it's kind of an inbred sort of thing, but San Diego and Sharp Healthcare is an amazing, amazing place that I'm super proud of, and I'm delighted to still be there. But a couple of years ago, we have friends that have a son, Bailey, and Mel and Connor. My wife is Deanna, my daughter Sydney, my son's Nicholas, and we all went miniature golfing together. So there was 7 of us. So you can't go 7 people at a time. So the guys went together, and my wife and Mel and my daughter Sydney went together, and they went first, and then we went. And by the second or third hole, we had placed a wager because that's how it goes. And whoever lost was going to have to buy dinner for everybody. So it was on at that point. And I had the front 9, I was on fire. I had like three holes in one, and the rest were 2s. And so I had like a 2 or 3 stroke lead coming into the back 9. And Connor and I have always been very competitive on a variety of different activities. And I get to like the 16th hole, which was an anthill. And I got a snowman. A snowman, that's an 8. And I lost everything that I'd worked for. And I remember apparently I had said something that I've told my son not to say, and my, at that time, 11-year-old son telling his 45-year-old father to relax. And we caught up with my wife, Deanna, and friend Mel and daughter Sydney, and I asked my wife, I said, how's it going? Who's winning? And she looked at me with a blank stare and she said, we're not keeping score. And they were hitting each other's balls and talking about stuff that had nothing to do with the game of golf. The process of measurement and performance feedback is a critical instigator, particularly among those that are competitive. And if you look at effective leaders and those that are able to drive and execute and manifest change, they keep score. And they use measurement as a verification of the pursuit and the execution of things that matter. So the purpose of physician measurement, clarity of our current performance to, again, wash away myth, self-perception, this is where we stand. And a toxic approach is to blame somebody else for it. Because you can't dismantle the measurement and respond to the data at the same time. Those are 2 mutually exclusive activities. I know that one for sure because at Sharp, we did that for 3 years. We were so bad that it couldn't possibly be us. So it was methodology, sample size, attribution, whatever. We're different, we're unique, our payer mix, our patients, whatever. It creates the need to change. It makes the argument in a comparative database that we need to move. The ability to align physician efforts to execute system goals, create balanced physician effort, because we talked about what makes for a great hospitalist, what makes for a great physician. We have to have all of those things. You can't just, if somebody is clinically brilliant and patients love them, but he's bastard to his colleagues and doesn't support them, doesn't respond to pages, well, is that still a great physician? You got to bring it all. And we have to have measures now that verify it. I'm not trying to be cruel or mean, but it's just how the world is right now. Create balanced performance, recognition of high performance, and to help physicians that struggle. When physicians fall out on particular performance measures, it's not you're bad, make it better. It's we need to deploy resources to help, and we will spare no expense for a physician who's willing to get help. We say things like the sample size is not significant, the measurement data is flawed, my patients, that wasn't me. But you know what? Nobody cares. It's not a perfect measurement. But neither is a stress echo for atypical chest pain, or mammography for breast cancer, or a whole host of tests that are loaded with false positives and false negatives that we use to adjust the probability of disease. And again, nobody cares. The attribution issue is a significant stumbling block. And all vendors, Medicare, everybody knows that that's an issue, particularly in the inpatient environment. The call to action is, that wasn't me, but the call to action is we all must do this. Because nobody cares that there's an attribution issue and everybody's got the same problem. So, we must couple the why to the how. We got to be able to figure out how to get this done. So, the things that will predict a patient walking away and saying, that was amazing. There's almost no correlation between the level of clinical quality as we define it and what patients say about you. You could be clinically brilliant and a patient can think you're awful simultaneously. It happens all the time. If you communicate brilliantly and you're clinically a farce, then you are a charlatan. Our clinical ability is the most important thing that we deliver. But if we fail to deliver on the patient's definition of a great physician, then are we really? So we got to deliver both. So, listened to, cared about, assured. Information transfer, shared decision making, clarity on what they're going to be doing at home. So all of the behaviors that we're going to coach and train will be fostered around these abilities. So how do you do that? And how do you do that? I want you to forget about HCAP's questions. You do these, you're going to crush those things. These are the things, the real visceral things that do it. So if you're going to say, okay, we want to make sure when you're done with the patient knows that you care about them. What do? Let's make this easier. In any friendship, in any colleague, in any son or daughter, spouse, any human interaction, what are the core elements of caring? What are the behaviors that express that prove that? Communication. All of this, absolutely 100% is there. But what more specifically about communication? How is it that we communicate to a patient that would make them walk out and say, you know what, I know that he or she cares about me. I know it. What's that? Empathy. Empathy. How well do we express empathy? You would, if I took you with me to shadow physicians and you watched what we do, you would say, oh my goodness, wow. Patients spill their guts, literally, on us and tell us their greatest fears, their greatest concerns, the greatest impact on their lives. And we are so stuck in a left brain clinical algorithm that we don't even stop to take a breath. So a physician who stops and pauses is a behavior that verifies that they care about me. It's like saying to your son or your daughter, I love you. But you don't go to the game, you don't go to the practice, you don't help them with their homework, you don't tuck them in at night, you don't ask them how their day was, you don't take them through tough times. But I love you, seriously, I do. They will assess you by behaviors. So we need to embed within that clinical encounter the thing that pulls that, that pulls that, that pulls that. The irony is, how in the world can we assure them if they have no ability by which the thing that should drive assurance, which is our clinical ability? They can't assess our clinical ability, so how do we assure them? How would you assure somebody? And how important is that? Of all the things that we deliver, that one is number one. You can do this, 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 this. If they think you're incompetent, game over. So we need to learn how to introduce ourselves in such a way that. When I joined the medical group, I was 29 years old and I was doing sigmoidoscopies. And back then I looked young. Now I'm 48. And I was doing sigmoidoscopies on patients that weren't mine. So no halo effect, no establishing history or connectivity. They would see me and go, I could tell. I didn't know back then really what this was, but it was a patient that was terrified that they were about to get something done to them by somebody who looks like they graduated from high school. So I learned the technique of introducing myself. Not in the spirit of arrogance, but in the spirit of confidence. Patients want that. I met a nurse from Tupelo, Mississippi, a 2-time Baldrige winner from Tupelo, only assistant to have done that. And I was shadowing their physicians there. And I spoke with the nurse who said she had thyroid cancer, a thyroid nodule that was removed that ended up being cancer. And she said, you know, I went in to see the ear, nose, and throat surgeon. The first thing the surgeon said to me was, I'm the best surgeon in the region. And she said, you know what? That's exactly what I wanted to hear. So our ability to leverage and position ourselves in those first few moments is how we provide this, how we introduce and how we transfer care, how that hospitalist introduces that nurse. What an amazing opportunity. This is Sally or this is Joe. I mean, it could be either one. We've worked together for the last 3 months. Best nurse I've ever worked with. She is fabulous. She can take great care of you. So she's going to take care of some things after I leave. You're in great hands. What does that do? That's free. And what does that do to that dynamic between those two? It fosters relationship and interaction, and so the nurses don't, those nurses before that intervention hated their hospitalists. They saw them as self-absorbed, self-consumed, insensitive, disengaged, selfish group of physicians. Outside of that, they were okay. But it really, and the docs pathetically had no idea. I said, do you think, what does it feel like to stand there next to somebody in this intimate patient encounter and stand there and not have anybody introduce you? Because they went in side by side. It's unbelievable. Anyway, so again, the beginning, middle, end of the clinical encounter. So we're going to focus mostly on the inpatient encounter. Greetings are one way to ensure proper identification of patients. It's considered a component, a fundamental component of patient safety. So anyway, so let's say you're going to go see a patient down in the ED, and we're going to actually run you through a clinical scenario. All right? And before I provide you all these things, I want you to think about how you do things and to reflect what I usually and customarily do, both in the outpatient and on the inpatient side. So you see a patient, how many primary care physicians here? Internal medicine, family medicine. So we've got 2. Specialty care, doing consults in the hospital, right? So you walk in, you do consults and you do continuity care both in the hospital. Is that right? Right? Yeah. So you see a patient for the very first time, you get a consult that's ordered, gastroenterologist, or whatever you may be. And you see the patient, what do? What do you say? What's your usual and customary thing that you do in the front end of that clinical encounter? Introduce yourself, right? How do you introduce yourself? Do you, yeah. I mean, introducing yourself is a very important part of the pathway. There is a constellation of things that we look for in how we introduce ourselves. And our ability, so we introduce ourselves, we make eye contact, we wash our hands, we sit, we engage the patient. Sitting is a critical element of the patient experience. I was at Oklahoma University last year, and the CNO told me this great story about the importance of sitting. She said very good friends of theirs their son had been seriously injured in a motorcycle accident and was admitted to the SICU. So she went to go visit at a different hospital their son in the SICU with his parents, their friends. And she was there with them, and they were waiting for the physician to come by. So she, as the CNO, nurse and friend, went to go approach the nurse to find out when the physician, or who the physician was that was taking care of their son. So she approached the nurse and said, "Who's taking care of our friend, son?" And she said, "You know, I'm not sure. I think it's just the resident." And then she said, "Okay, well, when is just the resident going to be here?" And she said, "I have no idea. They round at weird times." So that was the initial encounter. So they waited for just the resident, waited, and finally the resident arrives. Comes into the room, foams up, grabs a chair, sits knee to knee with the mom and dad, introduces himself to everybody in the room, and sits knee to knee to the mom, and says, "I'm Dr. Resident. I'm actually the trauma ortho fellow. Been here for 7 years. I work with a world-class team. For the past hour, we've been reviewing your son's films, planning our surgical approach for tomorrow. I understand how terrifying this day must be for you. I want you to know your son is going to do great." She said it was the most amazing 15 seconds she'd ever seen. And in those moments, all the fear, anxiety, worry evaporated. She still knew that there was a lot to go through, but never before in the SICU had anybody ever sat. And not just sat, chart up, leaning back, legs crossed, arms crossed, looking 45-degree off center, but knee to knee, connectivity. And she speaks about that on a regular basis. Our ability to knock on the door, shake hands. They need to see you wash your hands. You must. What are your hand washing rates here? Anybody know? Patients now, there is assume Dr. Oz, they've just seen the Dr. Oz show about disgusting physicians and what we have on our hands. That is an active campaign now, a speak up effort, and patients may very well be watching what you do. So, reference the primary care physician if there's some connectivity. That is, for them to understand and to pull the assuredness lever is, at my moment of greatest illness, are these strange doctors who I don't know, I've never met before, is there some connectivity with the doctor that I've had for the last 20 years as an active, proactive, deliberate reference, if you can. Sit eye level facing the patient, acknowledge the difficulty of their clinical circumstances. You know, to us it may be the 3rd consult of the day and it may be the 5th patient we're seeing or our 8th admission in a shift. It's a really big deal for them. And our ability simply to acknowledge that and to think about what would that be like if. Empathy is the ability to walk in another's shoes. It is emotional intelligence, probably one of the most important elements, certainly that makes for effective leaders, but I think for great physicians as well. Explain what you do, who you are, your training, your expertise. Don't be afraid here to pull this hard. Again, it's not in the spirit of arrogance, it's in the spirit of reducing the anxiety, explaining the team of hospitals and positioning if you are a hospitalist. Patients don't know what a hospitalist is. It's such a common part of our nomenclature that we just think of it on a routine basis, but patients don't know. And your ability to manage your colleagues up, position others well. If you're frantic, you need to not convey that to the patient. Because the intensity of the day can be overwhelming. We have to absolutely not convey that to the patient. Let the patient speak without interruption. We call it the 2-minute rule. 95% of patients will get their story out inside of 2 minutes. 5% can't get their story out in 30 minutes. Those tend to be the ones we remember. Paraphrase the patient history. Repeat the story back to the patient. We're talking about pulling the listening lever. We do that by paraphrasing this whole story back to them. Eye contact maintained. Information regarding their diagnoses. We are so bad at this. There's a study that released Mayo Clinic Proceedings that over 50% of patients leaving the hospital don't know their diagnosis. How is that? 67% of patients are given a new medication. 25% of those have no idea they were given a new medication. We have to convey the basic fundamental elements. When patients know their diagnosis, their home treatment, their precautions, return precautions, and treatment intent, and their follow-up, and the purpose of their follow-up, they do better clinically. And it offloads the burden of the healthcare system that is overcapacity as it is. The name of the condition, a simple explanation as to what it is, the natural history of the condition, the anticipated course in the hospital, how symptoms are going to be managed, and their concerns, fears regarding their condition.